Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Our host, Dr. George Netto, is the editor-in-chief of Modern Pathology and professor and chair of pathology and laboratory medicine at Perelman School of Medicine at the University of Pennsylvania. Here's Dr. Netto.
Welcome to a new episode of ModPath Chat. My guests today are Susan Prendeville and Shamini Selvarajah from the Department of Laboratory Medicine and Pathobiology at University of Toronto in Toronto, Canada. Both of them, and that's my own bias, both of them share our interest in prostate cancer, genomics, and Susan is a urologic pathologist, and Shamini is a scientist in molecular genomics, double or triple boarded, very accomplished young guest. And the manuscript that we're going to discuss today is about somatic tumor testing in prostate cancer. Thank you, Susan and Shamini, for accepting my invitation.
Thank you, Dr. Netto. It's a privilege to be here and delighted to be part of ModPath Chat and discuss our paper today.
Excellent. Thank you very much. So as we usually do, let's start with a little bit about the background. What motivated you to do the study?
Do you want to start, Susan, and then I can just touch on the genomics?
Yeah, sure, perfect. So, as you know, somatic tumor testing in prostate cancer has become very important, particularly looking at DNA damage repair gene defects in metastatic prostate cancer. And this is important because if we identify these variants, this can guide targeted therapies in the metastatic setting. So that was sort of the motivation and the background in terms of this particular study. When it comes to who we should test, there's pretty clear guidelines in the metastatic context. And if you look at guidelines like NCCN and other clinical guidelines, they recommend routine somatic testing in all patients with metastatic prostate cancer. Where there's not so much clarity is in the regional context. And so, again, guidelines have some rather vague statements, I would say, that, testing may be considered in regional disease, but there's no clear consensus or criteria when we should do this testing. And I think this is a bit of an evolving space as well, because, although at the moment targeted therapies are reserved for those with metastatic disease, there are ongoing clinical trials looking at therapies in the localized setting as well. So, for example, looking at neoadjuvant PARP inhibitors prior to prostatectomy, there's some clinical trials looking at that in high-risk disease. So I think, the indications and the scope of these therapies are likely to evolve over the next few years as we get data from those trials.
Excellent.
So, that was, I guess, in a nutshell, the sort of background of why we wanted to do this study and why it's important to look at these variations.
Excellent.
And so I'll just continue from there. So for us, we had been, as an institution, performing germline testing in prostate cancer for several years. And Ontario Health, which is the entity that actually reimburses labs to perform the testing, had been funding it. And then in 2021, they started funding tumor testing. And the criteria was advanced and metastatic. So this was where the lab geneticists, we started working with our pathologists to identify what is the best way we can perform the testing. And we felt that reflex testing would ensure that we don't miss patients. And as soon as the pathologist receives a diagnostic specimen and identifies it as appropriate for molecular testing, we receive the specimen and then we perform the testing and we report out the results. And so that paper is sort of, the findings of our first year of testing.
On a reflex basis. So as the pathologist is signing out the case, after signing, based on certain criteria that we'll talk about, decide to order the test. And given the reimbursement background, landscape evolving, you guys are lucky that that's the case in Canada. Wonderful. So we can talk about the cohort. I just want to, or we can talk about also the material and methods. So can you tell us a little bit, either one of you, how many patients, what kind of testing you did, and all that?
So just in terms of the overall cohort, we had 516 patients in total that were tested. And this included both our in-house cases as well as a number of referred in patients from other institutions. And within that, I guess a cohort of particular interest is our reflex tested cohort, which was all of our in-house patients. And that was 309 in total that we performed, reflex testing at the time of diagnosis initiated by the pathologist. So we did look at our findings across the entire cohort and then homed in a little bit more, in particular on these reflex tested primary tumors, which are of particular interest, I think, to see what we found there. In terms of the methodology, maybe, I'll allow Shamini to speak a little bit more about the NGS and so on.
Yeah, so for the actual NGS, we used a targeted custom design, or LDT NGS assay. So we use 2 or 3 NGS panels in our lab for various tumor types. And this panel that we're using right now is basically what we normally use for germline testing that we have adapted for tissue specimens. And so for actually the genes, we report on ATM, BRCA1, BRCA2, and POLB2, because these are the list of genes that was mandated by our province, but also at the request of our oncologists, we included MLH1, MSH2, MSH6, and PMS2.
Excellent. So basically, DNA damage repair genes, both group, the homologous recombination repair and the mismatch repair genes. And you zoomed in on the 4 genes that you mentioned and use the consensus CAP, ASCO, AMP criteria for classifying the variants, correct? So do you want to, Shamini, share with because that's going to become relevant for the findings, just a word about the 3 tiers of that criteria, classifying variants?
Yeah, so basically the way we have done it is most of our the variants, actionable variants, we tier them as tier 1 or tier 2. So these are, any kind of truncating variants or even missense variants where there is functional data that it does have an impact on the function of the protein. Now, copy number variants is a bit of a challenge with NGS because the admixture, the contamination with the normal cells sort of dilutes the content of the tumor, and so your CNVs can be depressed, like deletions. Mm-hmm. And so the panel really was not designed for copy number variants, and that is something that we're working on, because ideally with BRCA deletions, you want to be able to report out, distinguish homologous, or I should say, homozygous deletions. There's not much data on the benefit of PARP inhibition on the heterozygous deletions. And then, of course, tier 3 are variants where we do not have any information as to the clinical impact. However, we do include it because some of these we have learned end up being germline variants. So a cohort of the patients that undergo the tumor testing do end up getting germline testing, especially if they're metastatic, because that's one of the provincial requirements, or if there is another tier 1 variant. And we do not want to lose that tier 3, because if we do not report it, it sort of disappears from the patient record. And as you might know, some of these tier 3 variants do get upgraded when there is more information. And so we include tier 3 variants in our reports as well.
Very nice mini seminar on these tiers. So tier 1 is strongly of strong clinical significance. Tier 2 is potential clinical significance. That's why you're focusing on these two. And the third, tier 3, is unknown clinical significance. Mm-hmm. Wonderful. So what did we find here, Susan?
Yeah, I mean, so just looking, I guess, at the overall cohort, including our referred in patients as well as our reflex tested patients, we found, in line with what's known and what's been reported in the literature, that the rate of DDR variants was a lot higher in metastatic samples as compared to primary. Our positivity for tier 1 and 2 was a little over a quarter, a little over 25% for metastatic cases, and in the primary tested cases, it was about, I think, 13%. So that's very much in line with what we already know. And the other thing, I suppose, in terms of just looking at the overall cohort, was our HRR versus MMR. Again, HRR overall comprised about 12%. Again, talking only about tier 1 and tier 2, which are our actionable variants, whereas MMR was less than 3%. And again, that's, we know that they're much less frequent than our HRR. So that was sort of our overall cohort, including, our referred in cases, which were not our reflex tested cohort. And again, in line with the literature honing in on the HRR, the variants were most common in bracket 2, followed by ATM, again, which is what we expected to find.
So HRR is homologous repair. The accent is HRR.
Oh, yeah, sorry.
For the non-Australian, non-Canadian audience. Wonderful. So in terms of the rates were expected, but let's now focus on really what's somewhat novel in this study, or is an important contribution, because for the longest time in NCCN, the idea is, who do you test? Is having intraductal carcinoma or having a cribriform. Usually these are the ones that have homologous repair defects versus the ones that don't. So, but of course, while earlier studies based on small numbers showed that, later on people start raising doubt, including us in the NCCN, and it became not that important in triggering HRD testing or HRR testing. So how about your study? What did you find?
Yeah, so this was really, a big point of interest for us to see if as you mentioned, intraductal cribriform would have an association with HRR variants. And indeed, if the grade group itself would have an association with HRR variants. I mean, there is literature to support that these are more prevalent in higher grade cancers. And as you said, there's been controversy around the issue of whether IDC cribriform is predictive or not. Essentially, we did not find any significant association either with grade group itself or with intraductal cribriform carcinoma. When you look at the sort of breakdown in terms of primary tumors and the grade group breakdown, there was a higher frequency in grade group 5, but it wasn't statistically significant. And in fact, across the board between grade group 2 and 4, about 10% or so of all of the groups had a HRR actionable variant. And then again, looking at intraductal cribriform, because we didn't test routinely all patients with grade group 2, we routinely tested all patients with grade group 2 that contained intraductal cribriform. But in order to have a little bit of a control group, we tested a cohort of 30 patients with grade group 2 that did not have intraductal cribriform. And then we were able to compare, particularly in the grade group 2 patients, as to whether, grade group 2 or as to whether intraductal cribriform was predictive, and it wasn't. And similarly, when you looked at grade group 3 through 5 patients, we couldn't find a significant association between IDC crib and HRR variants. So I think it supports what has come out in other papers suggesting that, unfortunately, we can't use this as a criteria to select who should be tested or to triage patients for testing.
But this is a significantly large cohort, and I wanna just remind the audience, of course, please read the paper. It's an extremely well designed and well written paper. But the triage, the reflex, the way you've been doing it, and correct me if I'm wrong, everybody who's a grade group 3 or more get the reflex somatic testing on the tissue. Grade group 2 with IDC or cribriform also get those, and those who are higher stage PT3 or N1 and above radical get also the reflex. Correct? These are
correct. That's correct. Yeah, as well as obviously all metastatic patients.
Correct.
Yeah.
But for the regional.
Yeah.
So the regional, you're basically finding there is it's feasible. There is a relatively high rate in the regional, local regional disease, and that presence of IDCP or cribriform, because these are not the same thing all the time, at least according to certain societies. We don't want to get into that. Not necessarily impact the rate of having HRR. Great study again. Any closing remarks from either one of you about the study or future direction?
Yeah, I think what we found, there were a couple of big take-home points. So one is that when we looked at the rate of failures among our cases that were actual reflex tests, it was very low versus a lot of the consults where we had a higher percentage of failure. And that's partly because most of the consults that were sent to us were specimens of patients who had now progressed and who were metastatic. So it was at least 7 to 10 years in which, during that time that the block has been sitting around, not really optimally stored for molecular studies, and you've had fragmentation of the DNA. So the NGS very often would fail with blocks that were 7 years or older. Whereas in the cases where we did the reflex tests, because they were just recently fixed, we rarely had failures. So I feel like it sort of pushes or supports the use of reflex testing for this in this context. And the other thing we also found is when we were looking at tier 1, so clinically significant variants in the tumor, we found certain instances, and this of course requires a larger cohort study that Susan and I are working on. We found there were patients who had variants that were tier 1, but actually were recognized or well-characterized germline variants. But the patient was not really getting germline because either the tumor they were not metastatic, or the grade, it wasn't a very high grade. So they wouldn't really have met the criteria to have germline testing. But now that they've been identified as having a tier 1 clinically significant variant, we always do recommend subsequent germline testing. And so, that is sort of another reason why reflex testing will have such an impact on the clinical management of patients.
Excellent points. So because you start with somatic and then you may end up doing general. Although for metastatic, it's, I think the overall NCCN and ESMO is to do both germline and somatic at this point. But since your cohort is delving into a new territory of regional, that's a very important point. Excellent. Thank you very much. And I'm happy to see that pathologists will be in the driver's seat and start doing reflex on these, and hopefully future studies will on the decision support value of it in terms of treatment will pan out. Thanks again.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Elsevier, the University of Pennsylvania, or USCAP. Your ModPath Chat host and scientific director is Dr. George Netto. The producers are Dr. Catherine Ketchum and Carly Hess. Technical direction is provided by Kaminsky Productions. Music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.